I've got Ian Donald here with me today, and we're going to be doing a short section on frailty. Thank you for joining me today.
Okay, nice to see you, Hein.
Ian. So what do you mean by frailty in the primary care setting?
So I think what I want to say is a little bit about the technical definition, I suppose, of frailty. It's a word that people use commonly, and people think they know what they mean by frailty, but we're trying to give it more of a medical definition, I might say. So this first slide shows you how our central concept in frailty is really loss of reserve. So if I just follow through on the slide, you see the top curve there describes what we might think of as the normal aging process. So a gradual curve down as the years go along with you see the arrow on the left-hand side says about performance. So as the person gradually ages, so they don't perform so well. And on the right-hand side, you see another arrow going at the same time, which talks about homeostasis worsening. So if you can imagine that as you're aging, you're just losing a bit of reserve in each of your organs, in your kidneys, your lungs. You don't notice this, but you notice it when you have to run for the bus and you suddenly realise you haven't got the puff you used to have. So that ability, it also comes in the kidneys, so that if you get a bit dehydrated, if you've got a healthy kidney, you can manage perfectly well. But if you haven't got quite so many nephrons, you're challenged a bit when you haven't got that ability to reserve. So that's what happens with all of us as we age. But you see there's another curve here, just running parallel almost, but rather more rapidly. And that sort of person's got frailty because they're losing their reserve at a faster rate. In some ways that doesn't matter until you get below this dotted line that enters frailty. Before that, the person's losing reserve, but you'd hardly know about it. But once you get below the dotted line, then when you have a little incident and you need to call upon reserve, there's functional, disastrous consequences. So in that pre-frail period, you see a little dip in the upper section. You might not notice any loss of performance, any loss of function. But once you're below the dotted line, a little crisis, a little fall, a little infection, and suddenly that has a big impact on your performance. So that's what frailty is centrally about, loss of reserve, so nothing to call upon in a crisis.
That's really helpful. I'm thinking of people we see regularly in our practices that are actually older but managing quite all right. And then, as you say, it's just a chest infection or a urine infection or even perhaps a fall, and suddenly they really can't cope. So that's helpful. Thank you. So in general practice, what does this loss of reserve and frailty mean for us?
Well, it means bad news. My next slide shows just how bad news. As doctors, we like a disease we can get hold of. We know how to define a disease. We can put it on our register. We know there's a tablet for it and there's a blood test to show it's there. With this thing, we haven't got that handle on it. It's much more difficult. So it's not quite a disease. More bad news, it affects the whole body. And even more bad news, every person is different. So we can't give you simple rules, guidelines about you need to take each person and look at how the frailty is working in that individual. And when you get a crisis, the worst news of all, very often the whole lot comes tumbling down. It's not just the lungs that have gone, but it's the heart and the kidneys and the muscles and the brain. So it is challenging.
So Ian, I'm sitting in my GP practice or out on a visit. How can I actually spot a frail person?
Okay, I think you can spot a frail person. And I'm not just talking about somebody who looks dreadfully thin. One of the concepts and ways of defining it is what we call a phenotype. So if you see this combination of things that I've called here on the slide frailty phenotype, if you see, yes, okay, some recent loss of weight, this might be a heavy person who's lost weight, loss of energy, loss of strength, they're just slowing up in every sort of sense. And you're wondering whether should I do a whole lot of tests and scans and blood tests, but then you spot, actually, no, this is in someone who's 86 and this has been going on for a year or two now. gradually losing more energy and loss of strength. That's the frailty phenotype. You've spotted it. Another way, as you said earlier, patients succumbing to infections ever so easily, frequently, perhaps different sorts of infections, not just your usual COPD person, but somebody who's getting thing and they have a little bug and it seems to be a crisis. That sort of minor illness causing problems like we talked about earlier, the loss of reserve, that's a good way of spotting it.
So obviously we look after lots of different people in general practice, but if we're going to actually try and case find and actively look for these people, where might we look?
Okay, clearly the care home population is one place where you'd expect to find frailty, and so the majority of care home residents probably would be frail if we looked for it. Probably people who are recurrently falling are likely to be frail. Once one establishes moderate degrees of dementia, it's likely to be frail. And actually one could generalise, though there are many fantastically fit and wonderful 90-year-olds around, our surveys show that on average 50% of those people over 85 years old will actually have some degree of frailty. So age, yes, to some extent.
I've noticed on System 1 that we can actually do a electronic frailty index search. Do you want to tell me a bit more about that?
Yeah, so this is a new thing. I think in terms of its real value, we're still in the early stage, and I think we're waiting for some research studies to tell us a little bit more about it. But yes, it's been introduced into System 1, and I gather it's coming into EMIS Web during 2015 as well. So just a simple add-on that you can run, and it will split your older population into three categories of minimal frailty, moderate frailty, or severe frailty, and so that may well be one way. You're familiar with ways we used to do case management running with PAR and these different algorithms. So this one picks up a whole lot of read codes from your system. And so, yes, it's a very quick way of identifying frailty if you'd like to try it that way.
Okay, that's really interesting, Ian. But why would we want to go and find people who are frail?
Yeah, I mean, essentially because frail people do badly, have a poor outlook. They will be the people who are responsible for frequent admissions, like you're saying, on high-risk registers and so on. They're going to have admissions, they're going to have crises. So you can predict that, and just like you're used to with a COPD patient or a heart failure patient, the frail patients need a management plan. It may be a little bit more difficult than for COPD because you're not quite too sure how the crisis is going to occur. And so quite a lot of that crisis management plan needs to be around, well, who is going to be called, how are we going to get in help to support the person functionally over what's going to be a difficult week. Another thing you really can do is once you've recognised that somebody's frail, you should be thinking about reducing their polypharmacy. This is a time in someone's life when they benefit from investigations and medicalisation in general is going to be much less. There are far fewer rewards for these persons from treatments, investigations and so on. And in fact, you'll make the frail person feel better if you can reduce their medication. You'll actually enable that reserve to be a little bit higher because some of that reserve is being taken up or messed up by the drugs. So you really can help the person. You won't be consigning them to an early grave. You're really helping them to feel better if you can reduce the medication and the medicalisation more generally. And really, we want to spot frailty. In hospital, we want to spot frailty at the front door because we know those people are the people who have the least to gain from hospital and the most risk, in particular, the most risk from being in hospital. They have a lot to gain from a quick diagnosis, that's true, but then the focus has to be to try and get them out of hospital and supported again back into their familiar environment. So we in hospital are very keen to spot frailty to try to reduce the potential damage of being in hospital.
So what I'm hearing from a primary care point of view is it's very important from our side of things, but actually identifying someone and maybe sharing that information across the integrated community teams with our colleagues in secondary care and increasingly with our colleagues in social care and the third sector. So, yeah, very useful. But what can we do about preventing admissions when we know someone is frail?
Yeah, so this is, I guess, the holy grail in the whole topic of frailty, and often debated and disputed as to whether we really can avoid admissions. I think we can avoid admissions, but if we think of frailty as a long-term condition, we probably can't avoid those episodes of destabilisation. The same has been shown in the heart failure world and the COPD world and so on. Those episodes of, we might call them decompensation, are going to happen, but we don't necessarily need to admit the person to hospital at that time. And so it's a matter of finding other ways of supporting, exactly as you say, Hein, by working with our colleagues in social care. So crises will occur, but I think we can find other ways of supporting them collaboratively, working together.
Ian, finally, you mentioned this electronic frailty score. Do you want to just talk to me a bit about another one that people might be familiar, which is the Rockwood scale?
Yes, so in Gloucestershire we've decided that it might be useful to have a sort of shorthand about how frail is frail, because we say, oh, she's frail or she's very frail. So we've decided to adopt across primary and secondary care the Rockwood scale, which would categorise how severely frail somebody is. The scale runs from 1 to 9, and you see it on the slide there. And it has some pictures so that it allows you to very quickly sort of roughly put someone into a category. So it's somebody who's walking around the house and slowing up, but still essentially managing the routines, might be a category 5. Somebody who's needing help to run the house and probably now walking with a frame will be a category 6. Whereas somebody who's a category 7 is the sort of person who's now got a package of care coming in 3 times a day, or someone living with them to look after them. They really are dependent for personal care. And there are 2 more categories above that, as you see, 8 and 9, to define the most frail and vulnerable groups. So yes, a shorthand, and we'd like to try and use that across primary, secondary care so that we have a language to use.
Yeah, common language is always helpful in medicine. Ian, thank you very much for that. Really useful. Thank you.